nice to meet you. My name is Adrienne Dye. I am in the Digital Health and Analytics organization here at Humana in product development.
And I'm Jeff Morris, and I'm a product development professional in the clinical product organization. We have an acronym, we're the CPO, it's cool.
So just to give a little bit of background, Jeff and I, in a previous life, about 9-12 months ago, we're part of the Humana Innovation Team, which no longer exists. It became the new Digital Health and Analytics organization, the new Clinical Products organization. But while Jeff and I were together, we kicked off a body of work around how to help people afford their meds, no matter what it takes as a payer. That work has continued to progress, but we had the opportunity to share this work recently at the Health Experience Design Conference in Boston in April. And the Experience Center team invited us to share the presentation we gave here in the deck lunch. So we're really excited to talk about the work we did in the innovation team and how it continues to help our members get the medications they need to stay healthy. Anything else before we get started? Great. So I think a lot of you guys know a lot of what this slide is about. But when we were speaking at the conference, it was really helpful to just level set a little bit about really what's changing in our industry that makes the work we're working on at Humana extremely important and extremely vital. Humana is, like all businesses in the healthcare industry right now, really focusing on increasing its relevance and engagement with its members and providers. And really, it's important to realize that Humana is the leading provider of Medicare Advantage and Part D plans in the industry, serving 8.6 million members. We are very fast moving toward value-based care, with 67% of individual MA members working with physicians in value-based arrangements. Humana itself is really focused on two sides of the house now, right? We have the health insurance side of the house and the healthcare services side of the house. So we're not just an insurance company anymore. And because we're not just an insurance company anymore, we're really starting to think about social determinants of health and really how that influences our financial models, how we think about health, and how we think about insurance. And so all these things are coming to life in our industry and coming to life in our business. They're changing how we think about how we support our members, which really led to a body of work in the former innovation team around medications and how do we really think about how we support our members with medications to have one medication experience is what we colloquially started calling it. And it led to a couple particular programs at a handful of moments when members were having issues with their medications.
And the first program that Adrienne helped really charter a couple years ago, and the 3 permutations ago of the innovation team, because it got reorged every year for about 4 years, was around the post-discharge experience. So when a member is discharged from the hospital, they have all these meds. They may have new meds. They may have 2 meds that do the same thing. They may have 2 meds that interact with one another and are going to, give them kidney failure or make them even more sick. And so in that moment, a field care manager, which is part of our care management organization, Humana at Home, if the member meets a certain risk level, they go into the home, they check in with the member, see how are you doing after this hospitalization, they do a bunch of surveys, they do all this different type of work, and one of the things that they did was a medication review. And that care manager could be a social worker, they could be a nurse practitioner with 40 years experience, like their spectrum of medication knowledge was vast. So one of the things Adrienne and team did, this is before I ever joined Humana, was just sort of ask the question, well, what if they call a pharmacist who knows medications and can actually work through this list and from a more educated lens? And after that consult, there's all these different problems that they have. They call it a problem summary table, where it's like, you have to tackle this problem. Member, care manager, help the member with this problem. Physician, the member has this problem, you need to take care of it. And we had no visibility into whether or not those problems were ever actually resolved. And one of our colleagues who just entered at the perfect time, Elizabeth Metzler, looked at that problem list and found that the number one issue that we were seeing was about 10% of the time someone didn't have a medication because they just couldn't afford it. And so we started to ask ourselves, well, what is that? How many other people have this problem? Where else do these people interact with us when they can't afford their meds? And we found that in all of our different clinical systems, in all these different databases, we have information that says a member cannot afford their meds, or a member doesn't have access to food, or a member doesn't have transportation. Associates, whether clinical or non, are identifying these problems, but nothing really happens after that problem is identified. So we asked, well, instead of that happening all over the place, what if it happened in one place? What if there was one team that said, I can help you tackle all these problems, and we can find out if we actually resolve them or not. Next, we know, members have a very complicated, as I was just saying, a very complicated post-discharge experience. What if instead of all these different interactions they're having with all these people, they have a holistic experience around their medications, and every time someone sort of picks up that ball with the member, they are operating from the same med list, of the same problem list, and so they can help the member tackle the problems that are really relevant to them, not necessarily the problems that are relevant to that team or that specific campaign that they're working on at any given moment. Because especially our pharmacists in the pharmacy org may have different initiatives throughout the year depending on STARS measures and all sorts of other different things. But what if they're focused on the actual member problems? And then third, when those problems are typically identified, especially around medication affordability, you'll see nurses and pharmacists say, well, I've done what I can to help you. I can't really do anything else. Well, here's a number you can call. They might be able to help you. Has anybody ever heard, I'm sure we've all heard, TV commercials, if you have trouble affording your medications, AstraZeneca may be able to help. That's one of the things they do. That's called a patient assistance program. And they say, here's a link to a website. Go see if AstraZeneca will give you free meds. And then we leave it at that. So we sort of identify the problem. We say, hey, there's a solution. Remember, go check it out. Good luck. You're on your own. But then the big crux of our project, the big piece of it was, well, what if we actually supported members from that moment of problem identification until we know they have been able to secure that medications through whatever means are necessary. There's a couple different ways they can do it. There's those manufacturers patient assistance programs. The government offers a program called the low income subsidy, which if you meet a certain percent of the poverty level and all these other different conditions, they give you cheaper meds. There are grants and foundations that are focused on specific conditions or specific geographies. So if you have a diagnosis of sepsis and your income is below this dollar number for a month, we'll give you $1,000 to assist on your copay, and you can use that to afford your medications for sepsis. Or you live in this zip code, and we know you have that part of the zip code typically has trouble with this sort of social problem. So if you live there, you can have access to this thing. And we're going to help you get access to that thing, whatever it is. And so that's really what we did. We just tried to see, could we support members in these moments to try and secure their medications. But before we started that, we did the most important thing when anybody starts any project, and that is research. We sometimes discount research at Humana. We do not. We spend a lot of time researching to try and understand the problem before we just dive into it or throw bodies at a problem or throw money at a problem. It's, okay, what's the actual freaking problem here? Right? Is it because that people can't afford their meds, or is there another problem that's a little bit deeper that we should solve? So we did a literature and landscape review to understand what resources are available for members, how often these problems sort of manifest out in the world, not necessarily in the Humana population. We found those 4 different resource types I mentioned earlier: patient assistance programs, grants and foundations, the low-income subsidy. What's the 4th one? Oh, local support, which is just getting free meds from your doctor and things like that. And then we looked at, this is money and this is meds. In all of healthcare, this is the most relatable part of healthcare to manufacturing. Like a refrigerator, each part of a refrigerator has a cost, and that cost moves as the refrigerator gets built. Medications are very similar, right? They are a thing that costs money, and it moves from entity to entity until it gets to that end consumer. So we did a detailed view of how the money moves. Spoiler alert, it's really freaking complicated, and it's really, really hard. I spent 6 weeks on it and still feel like I know about 50% of it. Third, we looked at what sort of creative business models could Humana have in order to support members in getting access to medications. So we looked at different companies, different healthcare providers, to understand how are they supporting members. Massachusetts General has this amazing sort of resource support capability in their hospital systems because they own so much of the risk of the members. They say, if someone comes in and they're having trouble breathing and they don't have an inhaler, then they also realize that person doesn't have heat or they don't have food in their kitchen. They say, okay, forget the inhaler for now. We're going to help you get food. We're going to help you get heat. we're going to prioritize your problem, we're going to help you solve it. So we tried to mirror some of those best practices we saw out in the industry. And then finally, we looked at journaling. Humana is a massive company. There are initiatives all over the enterprise that we're still learning about, where it's some associate is helping a member get access to a thing, getting access to medications. And we found a team called the Life Assistance Line team in Humana at Home that did exactly what we thought we should be doing, which is they get members referred to them who are having trouble accessing some part of their care. About 50% of the time for their workload, that's medications in specific, and they support the member in trying to secure resources to overcome that barrier. So for us, it was they just help that member secure financial resources so they can afford their medications. There are lots of places all over the enterprise that also do it too. We call them cats because we're like, how do we herd all of these cats into like this one place where we're all trying to solve the same problem? And we got one team. There's still a lot of others out there still doing it. But it's complicated.
So, if you think about everything Jeff just said, right? We took a long time to really understand the problem, see what's out there at Humana, and what we really learned is, right, and this is our punchline, awareness is just the first step. Follow through is the hard part. And that team that we found in all that exploration in Humana at Home that was doing this, the differentiator, the thing that really made their work stand out, was that they had learned this and they had overcome it with our members. And so there's a lot of situations at Humana where we just give people a phone number and say, just call this person or call that person, and then we think things will magically happen. But the reality is, when you are a Medicare member and you have multiple chronic conditions, and maybe one of them is congestive heart failure or COPD, and you have medications that literally help you get off the couch, right? Help you be able to breathe, to be able to talk on the phone long enough to call one of those numbers and actually get the help you want to get. Awareness is just the first step. Follow through is the hard part. How much can we really expect our Medicare members to be able to take on their own? And what we realized is what we can do and what we started to build is how do we actually support people until their problems are resolved? And change the metric from, okay, well, we gave them some information, we made them aware, to we actually got them the meds they needed. And so we had already built that post-discharge medication reconciliation program. And we said, we had tested and learned into how to be present in a moment of medication change after a hospitalization and make sure that our members were connected to a pharmacist. And now we said, how could we test and learn into that moment and how to connect our members to a chief of resources, somebody to actually help resolve those complex cost barriers and include them as part of the care team. And so if you haven't already, there's this phrase at Humana, it's called test and learn. I probably already used it 4 times without realizing it. But it's the concept of how do we experimentally build a solution to actually test, is it desirable, is it feasible, is it viable? And so, we already knew that the care team we had, our pharmacists and our care managers, couldn't do this work. They today weren't helping members apply to these patient assistance programs or government programs or community support unless there were sort of extreme circumstances. And we also knew that our pharmacists and our care managers didn't really have all the available resources and awareness. And so we said, what if we took 5 pharmacists, 1 research specialist, and the next 100 consults that came through to these 5 pharmacists and just said, here's a resource specialist, they're gonna do whatever they can do, and let's just see what happens. Let's see if our members desire this type of person in their care team. Let's see if they can be effective to help resolve these unresolvable cost issues that our pharmacists are facing. Let's see if they can find those community resources and support these members and just learn. Just test into, can we actually follow up those members and resolve those cost needs? Because those community resource specialists have this deep expertise in those available resources, free up our clinical resources to focus on other more clinical work, and have a holistic view of the members. So while they may have been referred for medication issues, if they discover you actually also can't afford food or are about to lose your housing because you can't pay your rent, they're in a position to help our members with those situations too. Because one of the things our next big punchline is that medication issue or financial issues around medications are rarely the only financial issue that our members are having. So we pitched this test. What if we just took five pharmacists, 1 resource specialist, 100 members, and see what we learned? And our leadership said, cool, let's see what we learned.
But before they said cool, let's see what they learned. We had to overcome some orthodoxies, and with the test, we really had to overcome these orthodoxies. So we'd pitch this, we'd see, hey, like, just give us a couple months, let's see if we can do this test with 100 members. And some of the feedback we would get is, there's no way this makes sense for Humana to do. This is cute, this is nice, yeah, this is the right thing to do, we'll help these members who can't afford their meds, but come on, let's stop pretending that Humana has any sort of business position that doesn't work for us financially to help members in this way. And we called bogus, I was about to say another word, and we said, no, we think we do have an incentive to help. If these people can't afford their meds, they don't trust us, right? They look to Humana. While we want to show up as a healthcare partner to everybody, while we want to be a clinical partner, the vast majority of our members use the word insurance. You are the people who pay for my care. And so when I can't afford my care, it's your problem, Humana. And that's how they think of us. So we said, well, what if we show up and we say, hey, we're going to help you with this problem. You can't afford your thing, we're going to help you afford your thing. And in the long run, if they take those if they now have access to those medications, adhere to those medications and take them consistently, they're less likely to experience negative health outcomes, right? If people are sick, they need to be on their meds. Or if people are managing a chronic condition, they need the meds that help them manage those chronic conditions. So we thought we can figure out how to make this viable for the business. And we totally did. It's awesome. The next was, do we have that right to win? If everybody sees us as insurance, does Humana really have a place in solving these problems for members? Shouldn't they go to their primary care physician? Shouldn't they go to the local Medicare office? Go to maybe they have a social worker who can help them solve these different problems? And we really question that because we're identifying in a particular moment, that post-discharge moment, in that consult, we know you have a problem affording your medication. Why aren't we solving it? Right? We have uncovered that problem. We should solve it. We are the partner in solving that problem. And we got a lot of great feedback from members. I think we have some quotes later, where they couldn't believe that Humana was doing this, but they were so happy that we did. And then finally, we wanted to reframe some experience orthodoxies. Doing the work versus enabling accountability is kind of how we started talking about it. It's not just about, for a lot of our associates, they intercept a member, they have an intervention, they have the 10 check boxes they need to check, and then they're done with that member, right? They work through their pre-approved guidelines, and that's it. And what we did with our lead resource specialist that we were testing with was we said, you know how you usually have all these productivity metrics, if you need to make this many calls in this many days, you can only follow up so many times. There's this, if any of you interact with our telephonic clinical associates, you know the UTC3 rule, which is unable to contact 3 times. If somebody doesn't pick up the phone 3 times, we say, all right, we're disengaged, we'll call them back in a year. And we told the lead resource specialist that we were working with, screw all that, do whatever you feel like you need to do. If you have that member where you know that they'll pick up the phone, if they are able to pick up the phone, but if they haven't picked up 3 times, keep calling them until they pick up. The traditional model for this type of work is someone follows up with that member in 5 days, and then 30 days, and then they're done. And we said, no, follow up whenever you need. She was mailing things to them, so she would calculate, well, when's the mail going to get there? Okay, it's going to they're only just down the road, it'll probably be there in 3 days. So I'm going to call them in 3 days. And lo and behold, how'd she figure that out? She was always right. Like, the mail arrived that day, and she happened to call them. And the member's like, oh yeah, you know what, your letter did just arrive. And it created this new amazing experience. One of our members that we did a whole member research after we did this test and learn. And so Kim is the woman that we were working with, the resource specialist. And he said, Kim just kept calling and calling. I would forget what I needed to do next or wouldn't be motivated to keep going, but she kept things moving. I would have given up on somebody like me a long time ago, but she didn't. Right? Kim knew what needed to happen next in order for the application to actually get approval. She knew, she could gauge from her experience and from just caring about these people what their effort level was, how much they were willing to put in, and what level of motivation she needed to apply to this member to help them, sort of move the ball down the court and to get to that goal, to use some weird sports analogy. But she kept on following up. And
well, and go back real quick. One point there on follow through that we were talking about before, these programs are not designed to be easy to apply to, right? Speaking to a design audience, there are a lot of dark patterns that are built into a lot of these patient assistance programs and a lot of these other programs that put people in a position where your likelihood of qualifying is not great if you answer one certain little question wrong or one certain little question this way or that way. And that's something that, we can't train every member to do, and every member isn't supposed to be able to magically figure out how to answer this household income question that's worded in a really particular way to trip you up. And that's part of what Kim is able to do. And we can't understate that. I would forget what I needed to do next. I wouldn't be motivated to keep going, but she kept things moving because we actually took our expertise and shared it with those members who before they've never had access to this.
Yeah, thank you for that. Yeah, these applications suck. And all this is great, and all of our ideas and all of our theories were amazing, but we would have totally failed if we didn't have Kim. So this is Kim. She is I forget her title, but it's basically like, has anybody ever seen the movie Up? The balloons and everything? Everybody know the dog, Doug, with the collar? And everybody remember how friendly and loving and amazing Doug is in Up? That's Kim, and Kim is that in human form. She really is really compassionate. She really gives a crap about everybody that she talks to on the phone. She gets to understand them. She does what she can to build trust, and then she starts working towards the problem because she knows she can't just jump in there and be like, "Hey, did you do that thing? Hey, did you fill out that application? Hey, did you get your doctor to sign it?" No, she talks to them and she interacts with them in a human way. And this is her in her home office. She lives in Colonial Williamsburg, Virginia. She's an avid fan of the colonial time in America, even though she is Canadian. Her husband was a history school teacher in Chicago, and that's where they have retired. And so she works from home and she calls members all day, and that's what she does. And what she did was she prioritized every single day, approaching each and every member, showing that she was putting in the effort in order to build trust, and that showed something to the members, right? We always talk about, especially in the HCS world, how do we engage members? How do we get them to do these things? How do we get them to be active and engage with us? And instead of expecting them to take that first step towards us, we told Kim, no, you gotta, well, we didn't have to tell her, she knows to do this. You have to build the trust towards the member first. You have to show them that you care if you want them to actually do what you need them to do in order to secure their meds or go down a care path that they should, that's clinically relevant for them to go down. So she was amazing. She ran our 100-person test and learn, and we're still engaged with her we're on a pilot today. But Kim alone, with those 100 people, was able to see some pretty amazing results.
So back to our test, 5 pharmacists, 1 Kim, 100 members, and what were we able to achieve. So with this incredibly limited population, within a test and learn, right? We just sort of duct tape and bubble gummed an experience where our pharmacist said, I'm going to give your phone number to this resource specialist is going to call you, and then they're going to lead you through whatever they can do. What happened was we averaged $3,000 out-of-pocket spend saved per member who participated. Our members loved it. They raved about Kim. They raved about Humana stepping up to help them solve this. And our associates finally could sleep. Sorry?
3,000 over what year time? Like years, months, or
Just like immediate out-of-pocket spend based on engagement. So that was just a one-time out-of-pocket spend. Yep. And our associates also loved this because they were starved for help. If you think about what it's like to be a pharmacist and hear a member say, I am having trouble breathing because I cannot afford my meds. Can you help me afford my meds? Our pharmacists tell us that there's sometimes they have trouble going to sleep at night because they know they have members that they can't help that are going to go to the hospital in the next day, week, or month. We were able to actually build a foundation there's no trust between these members and Humana. So all of a sudden, maybe this insurer who was treating me wrong in other ways stepped up and actually helped solve an immediate need, helped me get that sepsis grant. So now I'm not going to have to worry about how I afford those meds. Help me get that patient assistance program so I've got my meds for the remainder of the year. Help me secure an immediate fill while I wait for my low income subsidy application to go through the Social Security process. We actually now have a trusted relationship with these members. And then, because we were able to overcome some of those orthodoxies and change the way our leadership thinks about this type of service and prove that we can actually decrease or impact our members' out-of-pocket spend and start to see impact from a viability perspective for Humana, our leadership agreed to continue piloting this experience to clarify the value. And so already that pilot is off the ground. Kim now runs a team of community resource specialists serving 2 different parts of the business, and you guys are already seeing great results.
Yeah, we had 100 members in our test and learn. As of yesterday morning, we have 1,001 members that have been referred over to our resource specialists to get help. So some of that $3,000 average out-of-pocket saving involves some more complex math that has to happen after the fact, because we have to see some of it's like avoided drug spend, which is hard to predict. You kind of have to go back and look at it. But just in the foundations and grant support, like the raw dollars, we've helped members secure $385,000 in money to help them afford their meds. And so that's $385,000 that the members wouldn't have had prior to interacting with our resource specialist. The low-income subsidy is a really great benefit, and I believe we have like 22 members who've gotten that. Which is fine. We wish it was higher, but there's like a whole team of people in another part of the org where their whole thing is like, let's go out and find these people who might qualify and apply. So it's not really our thing, but we're seeing great results. And we'll have more results at the end of the year.
So we presented this at a healthcare conference where we wanted to make sure the community of healthcare professionals and experienced designers like us had key takeaways, and that conference was focused on how do you actually address users' needs. And we really felt like this was such an incredible opportunity to do a body of work where all we did was solve a very explicit need that's coming up today in our ecosystem. And in doing this work, we had a couple actionable practices that we wanted to share with our audience. The first one, and this sounds maybe too simple, but it is financially viable to help people. We often think about this type of work as like, oh, we do it on the side, or we just do it to be nice. But no, it can financially benefit Humana by actually helping people make sure they get and take their medications. Do not ever underestimate the power of helping people, both to build a meaningful relationship, but then also to actually impact your bottom line. Awareness is never enough. We already talked about that sort of in the middle of the presentation, but again, if we actually want to see outcomes or see results or have resolution, sometimes you have to help. Sometimes you actually have to walk the path with a member or with a patient or with a user and make sure they can actually drive through that experience. And so if you're in any situation today, in a portion of Humana or outside of Humana where you are just giving people a phone number or a website or just referring to them, really ask yourself, is that enough to really see the outcomes you're expecting by just sharing that information? Because I bet in whatever situation it is, that awareness is not doing what you think it is. Define how you identify and escalate needs. On the same token, the crazy thing we discovered in all those cats floating around Humana is that there's a ton of places where we already know today that members can't afford their medications and people just don't do anything with that information, right? And if every single one of us recognized, well, what do I know about our member? How am I helping them? How am I actually empowering them and serving them and connect to other teams that are doing similar work and try to help make sure that you identify and escalate those needs? maybe we wouldn't have had to build this program because we would have already connected all the dots and start to bring together these teams that see these problems and address how to resolve them. And so definitely, if you're in a position where you know things about our member population, start thinking about how you're serving them, and if you're identifying needs, how you can escalate them and connect to in our Humana community. And then empower your associates to work top of license. Kim is Doug, right? Kim is Doug. She's special. But what's been incredible is to watch Kim train more Kims. She has a team of 7 now. We took this test and learn, and we actually changed the way our associates do their work to let them do an even better job and work top of license. And I know top of license is sort of a funny catchphrase at Humana. But really, the other way to think about it is empower your associates to take it as far as they can, go the final mile, and be there with our members. There's a lot of places in Humana where we don't do that today. We prioritize productivity, to Jeff's point earlier, over resolution and outcomes, and really ask yourself how you can think differently about those rule-breaking associates, because surprise, surprise, before we empowered Kim was a sort of a rule breaker that a lot of people didn't really understand why she was doing what she was doing. And now Kim is the standard. And so think about how you can change what the standard is for how your associates interact with our members.
That's it.